Imagine a scenario. It's one that every clinician dreads,
Oh, yeah.
but they probably face it more often than they'd like to admit. You're in the clinic, it's a Tuesday afternoon, and in walks an elderly patient, late 70s, let's say.
Hmm.
He sits down, smiles, seems perfectly comfortable, but there's one massive, glaring problem.
He is yellow.
Exactly, Frank Jaundice. He looks like a highlighter. But when you ask him, "Sir, how are you feeling?" he just shrugs.
I feel fine.
Right. I feel fine, he says. Maybe a little tired, maybe his clothes are fitting a bit looser, but no screaming pain, no colic, no fever.
The classic clinical mystery. Painless jaundice.
Mhm.
It is one of those presentations that just sets off alarm bells immediately in the mind of any doctor.
Or at least it should. So you send him for imaging, a CT scan, an ultrasound, and the report comes back.
And it says, dilated common bile duct, mass noted near the head of the pancreas.
And I feel like for 90% of people, even many in the medical field, the brain just auto-completes the sentence right there.
It's pancreatic cancer. Game over.
Exactly. It feels like a done deal, but, and this is a huge but, and if you stop there, you might be dead wrong. And being wrong here isn't just an academic error. It changes the entire conversation you have with that family.
Completely. About survival, surgery, the future, everything.
And that is precisely the mission for this deep dive.
Yeah, we're looking at this high-stakes game of whodunit happening in a very small, very crowded anatomical neighborhood.
We've got three main suspects.
Pancreatic cancer, distal cholangiocarcinoma, and periampullary carcinoma.
Three suspects. They all live in the same area code. They all turn the patient yellow, but they are very, very different beasts.
They are.
Yeah.
And our goal today is to move you away from just memorizing jaundice equals cancer and towards what I like to call elimination logic.
I like that.
We need to actually visualize the anatomy to figure out who the culprit is.
Okay, so let's start by setting the scene, because the terminology here is surprisingly slippery. We see the term periampullary carcinoma thrown around a lot.
All the time.
Is it a specific diagnosis, or is it a catch-all? Which is it?
That is the source of so much confusion. You have to think of periampullary carcinoma not as a single biological entity, but as an umbrella.
An umbrella, okay.
It's a location-based grouping. It literally just means around the ampulla.
So it's like saying downtown. It tells you where the crime happened, but not who did it.
That is a fantastic analogy, yes.
Yeah.
Clinically, we define this as any tumor arising within 2 centimeters of the ampulla of Vater.
The ampulla of Vater. It sounds like a villain's lair.
It does, doesn't it?
But it's actually that complex little intersection where the pancreatic duct and the common bile duct merge and dump into the small intestine, right?
Correct. It is extremely high-value real estate in the human body. Everything converges there. And within that tiny 2-centimeter radius,
The size of a grape.
about the size of a grape, yeah, you have 4 distinct anatomical structures, each one capable of growing its own tumor.
Only 2 centimeters. That is a crowded neighborhood.
It is packed. You have the head of the pancreas, you have the distal common bile duct, you have the ampulla itself, and then you have the lining of the duodenum right next to it.
So when a radiologist says periampullary mass, they aren't dodging the question.
No, not at all.
They're telling you, look, there's a lump in this 2-centimeter zone, and it could be any of these 4 neighbors.
Exactly. And here is the key insight from all the literature. Proximity does not equal identity. Just because these tumors grow next door to each other doesn't mean they behave the same.
Millimeters apart.
Literally millimeters.
Oh.
But their specific origin dictates how aggressive they are and, crucially, whether that patient has a probability of living 5 years or, 5 months.
That is a massive difference. Okay, let's meet the suspects. We have to start with the heavyweight champion of bad news. Suspect number 1.
Pancreatic head carcinoma.
The big bad.
The big bad. When we talk about pancreatic cancer in this context, we're talking about ductal adenocarcinoma. It arises from the pancreatic ductal epithelium.
And this is the most common one we see in this area.
By far. And it loves to sit right in the head of the pancreas. Now, to understand why it presents the way it does, you have to visualize the plumbing.
Okay, let's unpack the mechanics. The head of the pancreas is sort of wrapped around the common bile duct like a C-clamp, isn't it?
That's a perfect way to picture it. As the tumor grows in the pancreatic head, it doesn't block the duct from the inside. It squeezes it from the outside. External compression.
Like someone stepping on a garden hose.
Exactly like that. The hose, the bile duct, is structurally fine, at least initially, but the flow is cut off because of the pressure from this mass right next to it.
And it's a relentless pressure. It's not a stone that moves
Oh,
around.
no, it's a growing mass.
Yeah.
Which leads to that hallmark symptom, progressive jaundice.
So it doesn't fluctuate.
It just gets deeper and deeper yellow as the tumor gets bigger. But there's another clue the sources highlight. It's called the Courvoisier sign.
Courvoisier sign. I feel like we all learned that in the first year of med school, but let's refresh the why behind it. It's a palpable, non-tender gallbladder.
Yes. And the non-tender part is the real clincher.
Why is that?
Well, if you have a gallstone blocking the duct, it's usually acute, sudden, and inflammatory. It hurts. The gallbladder spasms. The patient winces when you touch them.
But with cancer?
With cancer, the blockage is slow, insidious. The pressure builds over weeks or months. So the gallbladder has time to slowly stretch and distend, like a balloon filling with water.
So it gets huge, but it doesn't hurt.
It gets big enough to feel through the abdominal wall, but because there's no acute infection, it doesn't hurt when you touch it.
That is a fascinating mechanical distinction. Pain means suddenness. Painless means slow, progressive blockage.
Precisely. Now, on imaging, this suspect leaves another calling card, the double duct sign.
And that's when you see dilation in both the common bile duct and the pancreatic duct.
Right. Because the tumor is in the head of the pancreas, it's positioned perfectly to pinch both tubes where they run together. If you see that, the probability of pancreatic cancer skyrockets.
And we know the risk factors: smoking, chronic pancreatitis, age. But the prognosis, the sources are pretty bleak here.
I won't sugarcoat it. Pancreatic head carcinoma has the worst prognosis of the group, period.
And why is that?
It's just biologically aggressive, and it invades the blood vessels. It sits right on top of the superior mesenteric vessels, the portal vein. By the time it's big enough to cause jaundice, it's often already wrapped itself around those critical structures.
Which makes surgery incredibly difficult, if not impossible.
Exactly. It's the neighborhood bully that invades everything.
Okay, so that's the worst case scenario. That's the one everyone fears. But let's pivot. Suspect number 2. This one can look very similar, but it's fundamentally different.
Distal cholangiocarcinoma.
Tell me about it.
This is where the anatomy gets granular. Cholangio refers to the bile duct.
Right.
So this isn't a tumor of the pancreas pressing on the hose. This is a tumor of the hose itself. It originates from the epithelium lining the bile duct.
So instead of stepping on the hose is clogging up from the inside.
Or the walls of the hose are thickening and hardening until the opening, the lumen, just shuts down.
Visually, on a CT scan, how do you tell that apart from the pancreatic mass?
It can be subtle, but you're often looking for what isn't there. You usually won't see a large hypodense mass in the pancreas. Instead, you'll see an abrupt narrowing of the bile duct or just distinct wall thickening.
More like a stricture than a compression.
That's a great way to put it, yes.
Okay. And clinical clues. The jaundice is there, obviously, but is there anything that screams bile duct cancer specifically?
Pruritus. Itching.
But doesn't all jaundice cause itching? I thought that was just a side effect of bile salts in the blood.
It is, but the literature notes that with cholangiocarcinoma, the pruritus is often disproportionately severe. Sometimes the patient is scratching their skin raw before they even turn overtly yellow.
A maddening itch.
A really maddening itch. But there's a massive historical clue for this one. If you see a specific acronym in the patient's chart, your radar should shift immediately.
You're thinking of PSC?
Primary sclerosing cholangitis.
That's the one. It's a board exam favorite, but it's also a real-life red flag.
It is the smoking gun. If you have a patient with a history of PSC, that chronic scarring inflammatory disease of the bile ducts, and they show up with worsening jaundice, you have to assume it's cholangiocarcinoma until proven otherwise.
That is a high-yield association. PSC equals cholangio risk.
And also liver flukes, though that's more about where the patient has lived. But really, that history of chronic biliary inflammation is the key.
Okay, so we have the pancreas, the external crusher. We have the cholangio, the hardening tube. Now we get to suspect number 3, the one the source material surprisingly labels as the good news.
Ampullary carcinoma.
And I'm using good in heavy air quotes here.
Of course, good is relative in oncology.
What?
But statistically, yes, this is a tumor arising specifically from the ampulla of Vater.
That tiny nipple of tissue where the ducts exit?
Exactly.
Why does being at that exit point make it better? Is the tumor itself less aggressive?
Not necessarily biologically nicer, no.
Right.
It's distinct because of the early alarm system it is built in.
The early alarm. Walk me through that.
Think about the plumbing again. The ampulla is the bottleneck. It's the very end of the line. And because that opening is so tiny, you don't need a big tumor to block it.
Ah,
A tumor the size of a pea can plug the ampulla.
I see. So with pancreatic cancer, the tumor might need to grow to the size of a golf ball to push hard enough on the duct.
Exactly. And by the time it's that big, it has likely spread. But with ampullary carcinoma, a tiny little lesion causes immediate obstruction. The patient turns yellow fast.
So they run to the doctor because they look like a Simpson character, but the tumor is actually still tiny and contained.
Precisely. They present at a much earlier stage. And because they present early, they're way more likely to be resectable. We can cut it out before it metastasizes.
And that leads to a significantly better 5-year survival rate.
A world of difference compared to pancreatic cancer.
There's a really interesting symptom nuance mentioned here for ampullary tumors. We said pancreatic cancer causes progressive jaundice.
Right. It just gets worse and worse.
But for ampullary, it can be waning or intermittent. Why is that?
This is a crucial detail, and it's a bit graphic. Ampullary tumors tend to be fragile and vascular. They grow out into the intestine.
Okay.
Sometimes a piece of the tumor will just rot. It becomes necrotic and sloughs off.
Wait, it just falls off into the intestine?
It does. And when that chunk falls off, the blockage is temporarily cleared, the cork is removed, the bile can flow again, the patient's jaundice improves.
And then the tumor grows back and the jaundice returns.
Exactly. That relapsing and remitting jaundice is a huge red flag for ampullary carcinoma.
And because it's growing into the gut, you might also see something else.
Blood. Occult blood in the stool. A pancreatic tumor is deep inside the organ. It doesn't usually bleed into the gut until very late.
But an ampullary tumor is right there.
It's exposed to the intestinal stream. So if you have a patient with anemia plus fluctuating jaundice, you have to think ampullary.
Okay, that is a fantastic differential framework. Let's synthesize this. I'm going to give you a patient profile. You tell me the prime suspect.
Let's do it.
Profile 1, 75-year-old male, heavy smoker, has lost 30 pounds in 2 months, deep, unremitting jaundice, and some dull back pain. You feel a mass in his abdomen, but he says it doesn't hurt.
That is textbook pancreatic head carcinoma. The back pain suggests retroperitoneal invasion. The weight loss is profound. And that palpable, non-tender mass is the Courvoisier gallbladder.
Prognosis.
Unfortunately, very poor.
Profile 2, 50-year-old female, history of ulcerative colitis and primary sclerosing cholangitis. She is scratching her arms constantly. Jaundice is present, but the weight loss isn't as severe yet.
The PSC history is the smoking gun here. This is distal cholangiocarcinoma. The severe itching fits perfectly.
Profile 3, 68-year-old male, generally healthy. Notice his eyes were yellow last week, then it seemed to get better, now it's yellow again. His blood work shows he's mildly anemic.
Fluctuating jaundice plus anemia. That implies the tumor is sloughing and bleeding into the gut. That is ampullary carcinoma.
Your early alarm.
The early alarm is going off. This patient likely has a small tumor and the best shot at a cure.
Now we have to talk about the traps. Because real life isn't always a textbook. Where do doctors get tripped up?
The biggest trap, by far, is the blood work. Specifically, the tumor marker CA 19-9.
Oh, right. The pancreatic cancer marker? I feel like that's how it's taught.
It is, and it's dangerous teaching. Yes, it's elevated in pancreatic cancer.
Yeah.
But CA 19-9 is basically a marker of biliary obstruction and irritation.
So it's elevated in all of them.
It is also elevated in cholangiocarcinoma. It is also elevated in ampullary cancer. You cannot use it to differentiate between these three.
So it confirms there is a problem in the neighborhood, but it doesn't tell you which house is on fire.
Perfect analogy, yes.
Another trap mentioned is the double duck sign. We said it's a strong clue for pancreatic cancer.
Strong, but not exclusive.
No.
Think about the anatomy again. An ampullary tumor sits right where the ducts join, so it can also block both ducts.
So you can't rely on any one sign in isolation.
You have to look at the whole picture. The history, the symptoms, the imaging, all of it together.
Okay, so we've used our elimination logic. Now, treatment. Does the specific diagnosis change what the surgeon actually does?
This is the great irony of this whole thing. We spent all this time differentiating them for prognosis, for counseling, but for the surgeon, if the tumor is resectable,
The answer is the same.
the answer is almost always the same.
The Whipple.
The Whipple procedure, or pancreatic duodenectomy, if you want the formal name.
Why is it a one-size-fits-all surgery? Why can't you just, cut out the little ampullary tumor and leave everything else?
It comes down to blood supply. The head of the pancreas, the duodenum, and the common bile duct all share this chaotic, interconnected web of blood vessels.
So they're all tied together.
You literally cannot separate the head of the pancreas from the duodenum without killing the tissue. They are inseparable partners. So if you have to take one, you have to take them all.
And if it's not resectable?
Then the path also converges. We can't cut it out, so the goal becomes palliation. We put in a stent to force the bile duct open, stop the jaundice, and then we refer to oncology for chemotherapy.
So the surgical decision is binary. Resectable, Whipple, unresectable, stent and chemo. But if the surgery is the same, why did we just spend all this time analyzing the differences?
Because the outcome of that Whipple is completely different. If I do a Whipple for an ampullary cancer, that patient has a decent shot at living another 5, 10, maybe 20 years. The cure rate is real.
And for pancreatic head cancer?
The recurrence rates are, unfortunately, much, much higher.
So the differentiation matters for managing expectations, for the family, for what happens after the surgery.
Precisely. It informs the adjuvant therapy, the surveillance schedule. You cannot counsel a patient properly if you don't know which neighbor you're dealing with.
Okay, let's do a rapid-fire recap to lock this in. I'll throw a concept at you. You give me the immediate association.
I'm ready.
Worst prognosis.
Pancreatic head carcinoma.
Relapsing and remitting jaundice.
Ampullary carcinoma. Think tumor sloughing.
Patient has a history of PSC.
Distal cholangiocarcinoma.
Painless, palpable gallbladder.
Courvoisier sign. Suggests slow, malignant obstruction. Usually pancreatic head.
And the treatment for all three, if caught early.
The Whipple.
And finally, what defines periampullary?
The umbrella term. Any tumor arising within 2 centimeters of the ampulla of Vater.
Perfect. This has been a really enlightening look at a very specific 2 centimeters of the human body.
It really highlights that painless jaundice is a starting line, not a diagnosis.
That's the big takeaway for me. If you are a clinician or a student, don't let the umbrella term blind you.
Right. Don't just say periampullary and stop. And don't just assume pancreatic cancer and give up. Dig for the nuance. Is there PSC? Is there anemia? Is the jaundice fluctuating?
Because telling a family, we caught this early, it's ampullary, and we have a plan, is a very different conversation than it's pancreatic cancer, prepare for the worst.
It's a world of difference.
I want to leave the listener with one final thought. We talked about how these tumors are neighbors, they share the same blood supply, the same drainage, the same zip code. But as we've learned, proximity does not equal identity.
That is a powerful lesson for all of medicine, really.
Just because things look the same and live in the same place doesn't mean they share the same fate. Anatomy is fixed, but our understanding of the pathology has to be flexible enough to see the differences.
Couldn't have said it better.
Thanks for diving deep with us today. We'll catch you on the next one.